Are live.
Thank you. Now live. Fortunately, the Commissioner of Corrections is not available, but we have a number of people here who are able to fill in for him ably and give us the information we were looking for. At our last meeting, we had a discussion of healthcare in Vermont prisons. One question from the committee. So I thought it'd be a good idea if Representative Evans agreed to hear from the department on prison health care. We heard from a number of advocates about lacking mental health care and lacking other things. And we also have a combination meeting today because we're taking up competency evaluation. So we have 2 members from Senate Health and Welfare and 2 members from House Healthcare joining us today. So why don't we start around the room? Is there anybody on Zoom in the on the committee, Peggy?
No, I don't believe so. Okay.
Will we start with Senator Norris and introduce ourselves?
Good morning, Senator Bob Norris, Franklin County, also Grand Isle, include Alburn.
I'm Martin Malone, representative from South Burlington and chair of the House Judiciary Committee.
Teresa Wood, I represent Huntington, Bolton, Bealsboro, and Waterbury, and I'm chair of the House Human Services Committee.
I'm Tom McFarland. I represent Barrytown on half of Woodland Town, and I'm on the healthcare committee.
Senator Dave Weeks, representing Rutland County. I'm a temporary assignee to the committee. I'm the vice chair of Senate Health and Welfare.
Leslie Goldman from the Bellows Falls area from the Healthcare Committee.
Izzy Rebecca, I represent Winooski and I'm on the House Healthcare. Senator Martine LaRock Ulick, I am a senator from Burlington, Essex, Winooski, Colchester, and Vice Chair of Senate Ed and clerk of Health and Welfare in the Senate. Thank you.
Irene Renner, senator from Chittenden North, which is the new district encompassing Milton, Fairfax, Westford, and part of Essex. I serve as the clerk on institutions and on agriculture.
Good morning. Jenny Lyons, Chair of Senate Health and Welfare, representing Chittenden Southeast.
And I'm Dick Sears, senator from Bennington County and parts of Windsor and Windham County. And also chair of Senate Judiciary. And
I'm Representative Alice Simmons from Springfield, and I'm chair of the House Corrections and Institutions Committee.
both Senator Lyons and I serve on the Appropriations Committee together. So with that, I'll turn it over to Christine Calver from the financial director of the Department of Corrections. I was going to say Department of Financial Regulation.
Thank you. I'm Chris Power, Department of Corrections. Good to see all of you. I'm going to walk you through the spreadsheet that we created, assuming that we absorb kind of the healthcare and relinquish an agreement with a private healthcare contractor. This is a pretty conservative estimate based on kind of the current state with salaries, staffing, and what we know to be operations of the system that we have now. Annie Remisiano is also with me via Zoom. She's the subject matter expert, so we'll kind of tag team questions in that space. First page here is the summary. This has a transition period, here in column B, as well as a 5-year outlook by category of salaries, systems, and contracts, pharmacy, operating, internal service funds, and then a total by year. So what I'll do is just walk through each tab of each of these categories, and then if you want to ask questions along the way, please do. And let me know if it's big or too small, and I'll try my best.
No, there's nothing.
No, I'm going to follow up directly after. We had a problem with the formatting.
Because it's really hard to see.
Okay, I can make it as big.
We can.
Is this what we would have in a comprehensive system, or is this what we have now?
A lot of it is rooted in what we have now to build the foundation of it. And then there's additional costs and staff added if we absorb the system.
It'd be important for us to understand what we need what we have now.
Yep.
What we propose, but also how do we get there? You're saying it'd be, yeah, I can count, so it's quite expensive.
It is, and I'll walk through all the pieces with each category.
What do we like? Maybe.
Yeah,
Healthcare expert.
no healthcare expert, good question. And obviously this must be based on needs and past experiences. But then also, one of the concerns that we always have is that so folks that go into corrections frequently are on Medicaid and they lose that. So it would be interesting to have some kind of prepared analysis of what we would see for this Medicaid.
Okay.
So what would be the current services, what would be the, I won't go too far to say Ron's fine, and say those, but certainly Medicaid. If there's a way that we could get some quick analysis of what that would look like.
Okay, I don't have that prepared as part of this, but we have Annie Remisiano, who's an expert, I would say, in the 1115 waiver, and we can discuss that.
State-run system rather than a contracted system.
Correct, yes.
But I wanted to understand what is not contracted for.
Currently, okay.
Currently, that would be in a state-run system.
Okay. So I hope to,
Because you know what the contract is. Current,
right.
I don't know what is not available. For example, is there a director of psychiatry?
Most of the staffing on this top section, the medical portion of the staff is existing in the current contract.
Okay.
As well as portions of this below area, which is sort of a central office or corporate level. And then once you're down here to the contract administrator and below, these are all additional staff that we project that we would need to be a state-run system.
We don't have a director of recovery and reentry, for example.
Correct. And Annie, please jump in.
We don't have medical billing specialists.
We do not. So all of those kind of business office type folks would need to be added. Discharge planners, grievance coordinator, we have in some capacity now, but would need to be increased.
So are those particular items, like the Director of Recovery and Reentry Services, Discharge Planner, Grievance Coordinator, is that being done now through our medical and mental health contract?
To an extent, but we anticipate that we would have to bulk up those services to be a state-run system.
Even if it were merged with another administrative entity.
A current, another department, is that what you're asking?
Yeah, like DEPA or.
Yeah, there would be a lot of collaboration with other departments that is not necessarily reflected here because this was, my piece was the cost analysis, but Andy can speak to other agreements we might have currently. Sure.
The Excel spreadsheets have been emailed to everybody. I'll try to get copies of them. Is there a copy?
Do you want me to try and have a copy with me?
Yeah, I think it would be important to have these documents. Yes.
Yeah, a question. So for instance, the discharge planner, the director of recovery and reentry services, so that is in the contract. And that's the only place that we get those services, or
On the health side of things.
on the health side.
Right.
So I seem to recall from the previous testimony that was one of the problem areas that we have. Or is the DOC thinking about supplementing what is through the contract with their own discharge planner or bringing somebody on? I mean, is it possible to have, I don't know if I'd call it hybrid, but where there are particular needs where we're seeing not the service we want through the contract, that could be supplemented through state employee?
I wouldn't say it's impossible. It's certainly, because it's something we could explore.
Yeah, it just seems to be, to me, that that was one of the big issues that we kept hearing was problematic, at least with our previous contract. But
Yep, understood.
Thank you. You can go ahead.
Okay.
Oh, that's another.
I just want to be sure it's not lost in the context of Senator Lyon's question regarding Medicaid and kind of scoping this out.
Yep.
There is a new Medicaid authority allowed, and I know we applied in our last waiver for the authority to offer MAT services to inmates prior discharge 90 days. And we were denied that in our last 1115 waiver. However, California now has kind of led the way, and now Medicaid is allowing reimbursement for those services 90 days prior release. I've been told that the state can't offer that. I'm curious if you could maybe bake that into another estimate, if others are in agreement that that might be helpful because of the cost savings. It'd be interesting to see that.
Yeah, I agree. Very interesting. I'm just getting my feet wet in the 1115 waiver space, so I don't have a ton of information, but it's certainly something we could do to kind of separate out what would be a general fund versus a Medicaid.
Yeah, thank you.
Yep. Any other questions on salary before I?
You go ahead.
Systems and contracts, this covers other systems that we would have to contract out to be able to provide the services. Currently, it's done through WellPath. They have these larger contracts that they use across all their clientele, and we're just a small portion of that. But we'd have to go out individually procure some of the services, such as the medical billing software, any dues or subscriptions, telehealth, EHR licensing, the electronic health record, and things of that nature. Those are reflected in these costs here.
I just want to go back. I'm sorry to do this to you.
That's okay.
Just thinking about salaries and
Yep.
how we currently pay for services, and we pay our professionals through pay per patient month, rather than sending a salary out. So how will that sugar off this one?
I think that would be a question for you all to restructure perhaps how the state's pay plan is structured for medical staff if we were to take this on. And I think to that point too, our salary estimates are pretty conservative in that area. I think, yeah, they're, we all are aware of our dependency on agency staffing and traveling nurses and the financial implications that that's had for not only us, but, other departments and healthcare statewide. So really being able to recruit and maintain a steady workforce, I think we would really have to look at salaries and lifting them above what we currently know is the state's pay plan. Does that answer your question?
It does.
Okay.
It's like this on work ahead.
Yeah, there is. If we move to this, yeah, there's definitely a lot of work ahead, many years.
Thanks.
Sure. Also on this tab, the internal service funds, I've calculated them out based on what we currently have in our own current budget to align with the cost of maintaining the system internally. Pharmacy, this is pretty high, but that's based on, Annie can speak to the formulary process that larger systems of healthcare have, essentially looking at like a wholesale model. We don't have that. We would have to partner with another entity or vendor to be able to have that established. And this reflects a slightly elevated cost because we would be purchasing on a much smaller scale than another healthcare entity might if they're statewide or regional. So that's how we formulated the pharmacy cost.
And that includes us from joining in with the DIVA PBM. Yes.
No, I don't believe so. Operating costs are your day-to-day. There's medical equipment at the top. Most of this is current to what we're spending now. Some is elevated for having to swap out new equipment and keep things current. And then the rest of it is your day-to-day, your rent of space and equipment, office supplies, wireless phones, employee travel, and things of that nature.
So I just want to be clear, are we currently covering all of this?
Some of the operating costs already exist in our health services division, but this is projected based on including all the new staff and taking it all on internally. So, and it sounds like it would be helpful if I separated out between current and new state of reality by, okay, I can do that for sure.
Looking at medical,
Mm-hmm.
X-rays, laboratory services.
Yeah.
Medical supplies. Is the well path paying for that, or are we paying for that through the DOC budget?
Much of it is included in the contract. There is a provision for, if we go over the budgeted amount, then we would pick up some, but most of this is rooted in what current reality.
So when you're talking about outpatient bed, so a person, an inmate is to go to UVM Medical Center or Dartmouth for a procedure for one day.
Mm-hmm.
That $129,000, is that for the procedure itself? Or does that also include the security that goes with the inmate?
The security staff, it does not include that. This covers the procedure itself and the medical expenses.
And that would be covered through the contract with WellPath?
It is now, yes. Anything else here? We corrected a transition period, understanding we would still have to maintain current services while we're onboarding the newer administrative staff, procuring contracts and systems and getting everything ready to go to flip the switch from a privatized healthcare contractor to the state-run system. This reflects the salary cost is about 60% of the new staff, thinking it would be just under a year's time where we would have an overlap of the new staff. System and contracts accounts for an EHR, the internal service fund, and other operating expenses related to contracts. Same with the pharmacy, we would have to build some sort of supply or start forming relationships with formularies or other entities. The current contract would still be in place while we were transitioning. So for that first year, 2 systems would be running. And this accounts for the 5th year of the current contract. Realistically, I think it would take that long to try to formulate this and get everything into place. The EHR. There would be a lot of IT kind of systems running and starting up during the transition period. So this reflects an ADS project manager that are typically recommended by ADS to kind of help us onboard new systems and software. And then we allowed for a health services project manager in a limited services capacity, again, because we would have to maintain both systems at the same time. So we would need an additional person to help us get everything in place. And the equipment is the same methodology to establish equipment, rental, or office space, and utilities, fixtures, things of that nature that we would have to put into place. Sign-on bonuses, this just goes back to my earlier point about recruiting quality staff and maintaining stable workforce. We think this, especially in the area of additional medical staff, would be necessary to recruit those folks.
Can you clarify the office space rental?
Yes, I don't believe that, well, this is speculative, that the Waterbury office complex would be able to absorb that many additional new staff. So this is based on the size of one of our current smaller P&P offices. The extra space that we would need to house that kind of administrative layer of the system would probably cost that much on an annual basis.
So I'm going to push back a little on that. If you go out to the Waterbury complex, that space, I know DOC has a particular space, right? But when you look at the complex, a lot of folks are working remotely.
Sure.
Not being used. So why not work with BGS?
Certainly could do that. Yep.
To find other space, or even within your own. I'm assuming quite a few people are working remotely. But there's a lot of empty space up there.
There is, I don't disagree. It wouldn't alleviate this area. Our footprint would still expand, but so not to the $650,000 tune, certainly.
So it's almost, these figures in this graph, it's really the worst case scenario in terms of you had to front this totally by yourself, regardless of combining with DEVA or Department of Health or other entities already within state government, right? Some of the services. Or you could
Yes.
do purchasing of a pharmacy, meds on a larger scope because you can merge with some other state entities. This doesn't
Yes.
include any of that.
I think, I mean, aside from the salaries, I think salaries might be the best case scenario, but the rest of it is really worst case.
Right. I think like at some point, that I'd like to understand. We have a 3-year contract with WellPath, am I correct? So it's all, you need to continue that contract.
Mhm.
But what is that contract lacking? Particularly what we heard from last meeting from advocates and others, particularly in terms of mental health, in terms of discharge planning and reentry, and in some of the more serious cases, the testimony that struck me was from the Defender General. All the testimony struck me, but particularly he said that the correction staff did a great job when there was an emergency, like somebody was having difficulty breathing, attempting suicide, whatever. It got bungled when it got into the WellPath or the prior contractor. And the medical professionals weren't handling the case as well as the guards, corrections officers who were supervising. And that struck me on the way home. Frankly, my best speeches are always on the way home.
That's why we have a long drive.
Yeah. But that struck me on the way home. The more I thought about what the Defender General, who's responsible for all the investigations into inmate deaths, what he said and what you presented here, I'm trying to understand what we should be doing right now. That's not being done. And so if we were to decide to make a switch to a state-run system of healthcare in our prisons, that'd be one thing, and that's a dollar and cents thing. But also, what is it we're not providing to inmates now that we need to be providing in order to provide? 99% of them are coming out, certainly discharge planning on medical issues. Now, I got a series of emails from Will Hunter about trying to get prescription medication for somebody who just got out of jail. And it shouldn't be that difficult. Anyway, I'm really interested in targeting what it is we're not doing, what it is we're not getting under the contract, and what it is we need.
Andy, if I could pass that one to you as more of a subject.
Where's Annie?
Oh, she's in this right now.
Huh? Oh, there she is. Hi, Annie.
Hi, Senator Sears.
Been a long time.
It's been too long. Hello, everybody. I'm Annie Ramnasianu, and I'm the Director of Addiction and Mental Health for the Department of Corrections. Those are excellent questions, and obviously this is what keeps me up at night. I was also on those emails, Senator Sears, as you know, and was part of the team working to restore the discharge planning medications for that specific individual. But the larger question you ask is, it seems like a simple one on face value, but it's actually obviously complicated. I would say, as a subject matter expert and having had a very heavy hand in developing the contract that we are now working with WellPath on, implementation is incredibly comprehensive. It's an incredibly strong contract, and it covers all of the best practices and really encompasses what Vermont believes in. The issue at stake here is staffing. What we continue to see is a very volatile staffing environment where it is very, very difficult to sustain quality care through training and supervision because we have such a rapidly churning population of staff who are travelers who are coming in and out. And it is a challenge for all of us to make sure that they understand the workflows, the clinical guidelines, and everything that goes into providing excellent patient care. So it's more, in my opinion, about contract compliance and supporting our contractor partner to achieve the joint vision that we all have for providing excellence in our healthcare system. So the discharge planning, I'll start there, and then I'll stop talking and see if there are other questions. But we are currently trying to stand up discharge planners, specialized discharge planners, to create a redundant and triaged system to provide people what they need when they release. So there will be discharge planners that are facility-based, that will most likely, we're developing the criteria now, be able to provide discharge planning, medications at release, et cetera, for people who are straightforward and less complex. And then, as I just said, we have built into the contract specialized discharge planners to help lift up very complex discharge for those individuals who need it. So we need to find and develop and retain strong staff. Otherwise, this all falls apart all the time. And as you know, you've seen the articles about the Vermont Psychiatric State Hospital. We've seen the staffing shortages impact the PIP sobriety housing across the state. Many of those facilities have had to close because they do not have staff to staff them. So we're obviously in the same boat and are being impacted by this on a constant basis. I will say that my experience with WellPath to date is showing me hope. It's providing me some uplift. They're starting to retain and attract staff that in positions that we have not been able to fill. The previous contractor was not able to fill. I think that their presence in the state, the culture that they're conveying through their interview process, their onboarding process, their corporate staff, the on-the-ground staff is starting to create an impact, a wave, if you will, of attraction to working in this system. We've also started a number of collaborations with the University of Vermont, which I'm extremely pleased with. We have a student group who's become registered with the University Medical School. There are about 8, but growing numbers of students who want to do rotations through our system. They also want to provide wellness and resilience programming in group formats. Soon with Dr. Jeremiah Dickerson, who's in charge of the psychiatric rotation. As you're aware, UVM did not sign on a contract with the state hospital, with the psychiatric hospital. So he will now, hopefully through this collaboration and with working with WellPath, we will be placing psychiatric residents to rotate through our own Department of Corrections system. And then lastly, I'll be making a series of trainings and presentations to medical students and to medical staff who are interested in forensic work, and that starts at the end of this month. So we're trying to build in more awareness about the exciting field. I think it's an exciting field of forensic medicine, and we're trying to build internal capacity through the university to attract and retain more qualified staff in our system in the future. So I'll rest there, but that's a little bit of, I think, addresses some of the questions you had, Senator Sears. And I know it's not hard and fast, but it's what we see.
Yes, underlines.
So Annie, thank you very much for that. I know how hard you've been working on this one, and it sounds like you've gotten to a good place. I did ask to look at the contract with WellPath, and I think it's being distributed. I have it, and that's been sent out.
Yeah.
Just to look at it. Obviously, we've met about this previously, and one of my concerns continues to be, there's a dearth of workforce out in the community and a dearth of workforce in our forensic facilities, and it all comes together. And then when we try to build a mental health system, for example, within public safety, we might see increased salaries in those areas that pull people away from the community. So it becomes some of these catch-22 things going on. So I think it will be important going forward. I don't have a conclusion but I think it's just important that we continue to work together, both from the forensic side, judiciary side, as well as the healthcare side, because I know, continue to do that. But so thank you for your work. And we just look forward to continued dialogue on this.
Me too. And thank you for your recognition.
Yes.
Annie, I'm not sure if this is a question for you or Kristen, but I'm curious, just very big picture, high level. When crafting this plan, I know you're thinking, perhaps 3 years out. Does it account for and align with the direction that AHS and particularly DMH and VDH are thinking in terms of the mental health system of care and the way that that's evolving in terms of best practices and federal funding and integrated models of care that would really get at improving outcomes for residents in Vermont and also aligning with our new all-payer model? I'm particularly interested if this aligns with what our designated agencies are pursuing. And that's the CCBHC model, Certified Community Behavioral Health Clinics. And I know our state also received a planning grant for that this fall. So I'm just curious because there are a lot of benefits of that could work within this system. And I think many of them are on, the back office end. And so I'm curious where you see that fitting in and whether you align this model with the way that DMH seems to be thinking, as well as the way that the providers are really pushing the state system.
No, absolutely. Excellent question. And yes, 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 and yes. So I represent the department on all of those committees. And I absorb everything like a sponge and translate it and apply it back into our own system. So I really do see my role as a connector, a big vision thinker, and to bring all of the best that the state has to offer back into my concentrated area. As I said, I was on that task force. We included actually some of that language in this contract about the integrated system. I don't do anything without the health department. Dr. Levine actually reviewed many of our documents that are part of the mental health workflow. He asked to review the receiving screen that every single person is given within 4 hours of admission, and he gave it a big thumbs up. So we are working with all the other departments in state government. We cannot do this by ourselves, nor do we try to. We are constantly seeking subject matter expertise from every other friend and ally in the Agency of Human Services and also in public safety. So, and then nationally, always speaking to my colleagues. There are 58 of me in the country, including US territories. And I have a listserv and we talk to each other all the time. We are looking at what everybody's doing in every single corner of our universe. And using it to inform what we do inside of Vermont. I have to say, I'm sometimes disappointed because we are so on the vanguard of most of the rest of the nation that when I present what the department is doing in these forums, there's usually just in silence because they are probably 10 years behind us. I know that the advocates are concerned. I am too, in providing quality care to every single person who crosses our threshold. But I do want this body to know that we are leading the nation and have been doing so in so many areas for quite a long time. And I just think sometimes that gets lost in some of the other concerning areas that also pop up. It's a constant quality assurance improvement process. But yes, Representative Woods, we are looking at all of that and more. Have you all been on our website recently to see some of the new research that we've promulgated with DEVA? For instance, as an example, we've been engaged in a longitudinal study on the outcomes in engagement and retention and treatment post-incarceration on MAT, and the results are absolutely staggeringly positive. Chronic disorders and medication compliance are within the top 3 issues of why people become rehospitalized and cost us all a lot of money. And we had incredibly high retention post-incarceration on medication-assisted treatment. So that's just one tiny example of a very massive collaboration that people don't see, but is happening every day. Another one that's about to be published, we're waiting for the secretary to review this policy piece, but we've been working since the pandemic with the health department on their 3450 brief, because we wanted the Department of Corrections to really be understood by the rest of the state to be the 14th county hiding in plain sight. We're comprised, obviously, of citizens from every corner of our state. And I think really understanding their chronic health profiles, tracing back their origins of county, where they came from, can be incredibly important to understanding what we need to do to strengthen the rest of the community-based system before people become incarcerated. And then when it will also inform us to improve those connections and those collaborations with Blueprint, et cetera, when people release. But this brief is, I think, seminal in its work. When I speak about this nationally, no other state that I have spoken to has said that they've been doing this work. I think this is really important because, as you know, we don't bill Medicaid. So all this health data is basically in a black box. We need to take it out of the box and we need to look at it. We can't solve problems unless we acknowledge they exist. Part of our challenge is the complexity of the individuals who come into our care and their very presentation. Probably no insurance company would ever insure this risk pool because they are not well. So I think we need to look at for solutions, shoring up the system from the community into corrections, from the corrections back into the community, and we need to look at this holistically. So that's a big part of the thinking that goes on in my division.
I have a question. Looking at the contracts on bottom of page 16, top of page 17. Patients with an SFI or SMI will receive daily visits from qualified healthcare professionals to assess their status and initiate, refer for any needed changes in treatment regimen. These assessments will document physical observations of patients' affect, any suicidal or self-ideation, and health complaints. The needs of the patients who are experiencing current severe psychiatric crisis, including acute psychosis and suicidal depression, will be addressed promptly, consistent with the patient's willingness to accept treatment. Alternative placements consistent with their security, health, and mental health needs will be considered. How many inmates are covered under this, and do they receive the daily visits? And is that 7 days a week, 5 days a week? You know?
Yes, I do. So just for your awareness, this data is published, I believe, monthly on our website. There are several SFI reports that are, in public view. On any given day, time, there are between 48 and 60 people who receive this designation. As per statute, there are two manners in which people receive this designation. One is through verifying a contiguous designation of having a waiver, a community-based waiver upon being incarcerated. This was one of the first systemic pieces of work that I did when I became appointed to this role. We worked across the Agency of Human Services, braiding and blending all of the databases across the Agency of Human Services that contain this type of information. And we have one staff person who part of their job is dedicated to running new intakes through those databases to find out whether or not they have any of the qualifying waivers as per the statute. So that is called an administrative designation of becoming somebody with SFI. And then the second way that people become designated SFI is through clinical assessment once they are within our walls. We use a tool called the Corrections Modified Global Assessment of Functioning. This was developed through a SAMHSA grant in collaboration with the Department of Corrections in Connecticut. I was trained by the director of nursing in this tool, and our system has been using this now for, 7 years. And through the diagnostic criteria in statute of what is a qualifying diagnosis, plus determining that their level of functioning is significantly impaired, the medical staff, in this case, WellPath contractor, has medical autonomy in all things, will then make the decision to designate them SFI. The mental health chief, Colleen Nilsson, and I both can request, obviously, if we become aware in our auditing and our information gathering, become aware of somebody who seems to be struggling, we can certainly ask questions and ask for an SFI assessment to be conducted. But ultimately, because of medical autonomy, the contracted staff, under all of their individual license as well as the contract, have the authority to make that designation or not.
Does this requirement include people that are on detention?
Yes, it's regardless of legal status.
Okay. And how are people who are there for competence, who are there awaiting a competency evaluation, how are they treated in that daily check? Are they daily checked? Are they considered to be competent or incompetent?
So
how do we deal with that?
How do we deal with that? So that is, again, a partnership with DMH. You all know that we worked very hard with DMH with Act 78 and trying to ensure that the department was using the same criteria as psychiatrists and others, other people who assess serious mental illness, the same processes to ensure that our population was not discriminated against in being able to access psychiatric hospital level of care. So this is a little bit in the same boat, if you will, that we work with DMH when somebody is being held by us because we're waiting for a bed in the state hospital for competency or a competency exam by a forensic psychologist, etc. If they meet SMI criteria within our walls and are able to be designated SFI, they would basically have dual status with us. Whatever we're waiting to be informed by the competency external evaluator, will be informed. We don't necessarily get that information because those are court ordered. And unless the client signs a release for us to know, DMH can't share the results of that assessment. That said, it doesn't really matter because they're with us and our healthcare providers are looking at their symptomatology and their behavior and their wellness or lack thereof every day. And we're doing our own healthcare with them. So it's really a side-by-side play.
What about somebody who may have a developmental disability?
Again, same rules apply. And in that case, our partner is DEVA and also Dale. So we'll be looking to see whether or not they have a community-based waiver. If they do, they automatically would be administratively designated SFI. If not, we would still be looking for community records, but Dale would be our partner on that end. Now, obviously, people also don't fit into neat boxes. So a lot of times we have everybody at the table because there's a little bit of developmental disability. Somebody might be on the spectrum. They might also be expressing and have a history of severe mental illness as a diagnosis. And then we are having giant multidisciplinary team meetings, not only at the AHS and central office level, but we are obviously having that translate down to our contractor. And the contractor is also trying to mirror those activities and provide the supports that the individual may need.
Senator Lyons.
So we've just gone through a whole breadth of issues that we are currently dealing with, and I know that you're dealing with as well, that are extremely complicated from a personal level for folks, and their mental health and their disabilities and how they're handled and treated within the community, or what facilities are available for their treatment. So as you're looking at the SFI, SMI issue, then it indicates here that there could be an alternative placement for some of these folks. And so what consideration are you now giving to that? I understand there's work going on with all of this outside of this environment, this committee. There are other committees working, but what are you thinking at this point in terms of providing for a facility or a place where folks with disabilities or mental health issues or have serious functional impairment might be best served?
Oh, Senator Lyons, you're asking the golden question. What would the world look like if I had a magic wand? So we're getting part of that magic wand experience, I hope, within the next 12 months. And that is the work that Dale has been doing in service of our forensic population. Obviously, people with dementia are becoming part of this population as the population ages. We have teed up to this point probably 25 to 35 names of individuals who we are now screening for whether or not they need nursing home level of care, whether or not they would meet CMS criteria for nursing home level of care. Dale has signed a contract with an entity who is in the process of purchasing a nursing home that's vacant. The number one priority population for that charge is the forensic population. So we are really, really excited about this because it's just the humane thing to do, is to provide true nursing home level of care for these individuals. Now, that said, there's always a public safety element to this too. And our director of classification has to look at their charges, their history, their potentiation for violence. And we have to look at the whole package that each person presents with and determine whether or not a community placement is also going to be viable. That said, I'm pretty sure we have cleared that hurdle with 25 to 35 people. So we're beginning that process for those individuals so that we are ready to hit the ground running and to make sure that their long-term Medicaid, which is like a 35-page application, that all of these bureaucratic but necessary foundational structures to allow this transfer and for the nursing home to receive payment for these people is all happening so that we don't miss a day from when they open to when these folks could actually be transitioned and transferred there. So that's one discrete population that we're very, very concerned about and is part of the big question that you just asked me. The other parts, the other people who are really complex, you know, it is so hard. So many of these individuals have such challenging behaviors that it is difficult to manage them in a group setting. I believe that many of you are aware of somebody who has this profile who's at Chittenden, and we have been working with Dale and with DMH for quite a long time. This individual has challenged every psychiatric hospital and every hospital in the state to help understand the conceptualization and the interventions that may be needed. And we are still waiting and working with Dale to acquire a house for a micro residential, which, as you know, is extremely expensive. So it really is case by case, what's in the best interest of the individual. And what we struggle with the most is the process of how do we have a high level team of subject matter experts who can convene, who have authority to help us move this ball down the court to finally and eventually get a resolution for the individual. And it's not easy. It's not easy. So I don't have a hard and fast answer for you, Senator Lyons, because we haven't gotten there yet. And I think it depends on this body and obviously the executive branch as well of, does our state protect the most vulnerable? What is our goal? What is our end game? And how do we do that? Because the department is open. We're open for business. We want help. We need help. We can't do this alone. But we ultimately simply become the placement of last resort. When we deinstitutionalized everybody, we actually decided to institutionalize them in corrections. And that's where we are right now.
Thank you, Annie. I don't know if there's any other questions for you or yes, Topper.
I have one. It's probably an easy one. It may be a little bit off this subject, but when the commissioner was here last meeting, and some of the advocates, there was statements were made that medicines that people needed, they either weren't getting them, they were getting too much of them or too little of it. When prescriptions were changed, they weren't followed up on. And we asked the commission to look into that and deal with, because that was something they could deal with. I think we're talking about giving the best health care that we possibly can to these people. That could be a big problem.
Isaac, do you have a response to that?
I think I would defer to Annie in this.
Okay, Annie, do you have a?
So I hear you. We all did the work on Act 153 back when we passed Act 176. Act 153 was, I transpose the numbers. It's either 135 or 153, sorry, was really about codifying that we want to continue all medications that are active prescriptions in the community as soon as practicable and possible upon incarceration. So that is a law that we take very seriously. It's embedded throughout the contract. The contractor is definitely aware of that. Now, the trump card to that is if there is a contraindication upon intake, that person is taking illicit substances that are dangerous to be taken in combination with existing active prescriptions, our providers have the medical necessity and the authority to modify what that individual receives until those illicit substances have washed out of their bodies and their metabolites are no longer a threat to their health and well-being. So there are instances where somebody will be temporarily taken off and then can be reinstated. There are other issues. You all may or may not know that there are national drug shortages at times. We are in one of those times right now. One of the most used attention deficit disorder medications, there is a national shortage. We have posted information on the incarcerated individuals' tablets. We have sent out press releases and other information about this. We are struggling to maintain and provide alternative treatment plans to address the health needs of people in the face of this shortage. Then there are other times where people misuse their medications, and doing so presents a health issue for them and potentially for others. It's the discretion of the provider, the prescriber, just like in the community, to decide to provide an alternative treatment plan, to possibly cease that medication and seek another substitute, even behavioral health. There are so many reasons why a provider may decide to change something. What we also really insist on is that if that change is needed, the law says that a face-to-face meeting must happen. All of this must be discussed with the incarcerated individual, and they have to be given information about what is happening and be involved in their care. We also give them the option of signing a release so that the provider can also discuss this with their community-based provider and inform them of the change. So my answer is, again, not a simple one, because there are many different cases where I'd say the majority where absolutely medications are continued and everything is hunky-dory and fine. There are other cases, because of all the different case studies I've just discussed, where an alternative treatment plan may be indicated, but it's on a case-by-case basis. There is no policy within our clinical guidelines or the contract where we just summarily take somebody off of a medication without any reason. We pride ourselves in Vermont to not practice correctional medicine. We do not believe in correctional medicine. We only believe in healthcare. We want the same healthcare inside of the walls as we have in the community. There is no correctional medicine.
Are there any other questions for Kristen or Rob? I mean, I'm Steve. She's just Annie. Our next witness is Robin Hodges, from the Vice President of Mental Health for WellPath. I believe she's on Zoom.
Sure.
Thank you for joining us this morning. We've heard many of the questions, Robin, and go ahead and introduce yourself.
I'd love to.
A little bit of a summary of what mental health services are available to Vermont inmates under WellPath, and what isn't available that you might think should be under the country, under a different scenario.
Absolutely. Well, thank you very much for having me. I appreciate the opportunity to speak with you guys today. As mentioned, I'm Dr. Robin Hodges. I'm the Vice President of Mental Health for the State and Federal Division for WellPath. Just a little bit about me. I'm a psychologist by training. Been in corrections about 17 years in various clinical and leadership positions. I spent the majority of my career, about 11 years, in the Maine Department of Corrections, and there worked to sort of develop the intensive mental health unit, expand SUD treatment, expanding sort of mental health treatment in general, as well as developing and implementing the MAT program. I'm also the chair of the Transgender Health Committee for WellPath. And I feel really privileged to be able to provide the services in the state of Vermont, providing quality mental health care to the patients in the facilities, as well as MAT services. As Annie mentioned, the state of Vermont is very progressive, so I'm really excited about joining you guys and sort of your mission moving forward. To answer your question a little bit about our vision for mental health in general, I think that's a great question. And what we offer in the facility is, your traditional mental health care that's available out in the community. So our mental health services are an integrated process from intake all the way through treatment in the facilities and then transition to the community. And we look to provide kind of a better range of services for all of our patients. Strive for the increased coordination of care across disciplines to appropriately kind of address our high needs patients and better address kind of the full range of their needs and treating the whole patient. So we're really focused on providing excellent behavioral health services for our patients in Maine. We recognize that obviously suicide is a leading cause of death in correctional facilities. So we place a pretty high importance on suicide prevention. It's also Suicide Prevention Month. So we really follow the National Zero Suicide Model. We prioritize providing psychiatric services. I know Annie touched on that a bit. And we're focused on providing our patients with a collaborative experience, meeting them in a kind manner, having them participate in their treatment plans, and really sort of be a collaborative, informed patient in their healthcare. We're also committed to providing MAT, as were discussed before, as long as the incarcerated individual is deemed medically appropriate. And we're committed to providing care for our transgender folks. Obviously, in incarcerated folks, histories of trauma is very prevalent. So that puts them at risk for reentry into the criminal justice system. So we focus a lot of our treatment on kind of trauma-informed, gender-responsive treatments. Our staff are trained to treat all of the incarcerated individuals in a trauma-informed manner. And most importantly, I think, is really with dignity and respect throughout that treatment process, with the delivery of each treatment component. And services are tailored to address kind of cultural needs, race, ethnicity, physical disabilities, mental health issues. Kind of in general, our treatment philosophy emphasizes that treatment takes context in recovery principles. So it's trauma-informed, person-centered, and that we encourage our patients to kind of take responsibility for their recovery and personal growth. And then, also encouraging them to break the cycle of substance use, criminal behavior, incarceration in general. We want to help our incarcerated individuals develop a sense of empowerment and hope. So in general, our treatment also focuses on psychiatric stability and community living skills, emotional support needed to kind of facilitate their time within the correctional environment. And then most importantly, setting them up for success for reintegration back into the community following their time in custody. And so in general, we look to really sort of treat the whole patient versus like kind of siloed out services. So one of the things that we're really focused on for our mental health care is treating the entire patient versus, we don't want to just sort of target different things. We want to make sure we're treating everyone in a very collaborative manner, whether that's with mental health and medication-assisted treatment, or with our healthcare team, if we have a complicated individual with a lot of healthcare issues. So I don't know if that answers your question.
Yeah, Representative Evans has a question.
So you said all the right words. How do you ensure that it's all carried out within the walls of an incarcerated setting?
Absolutely,
Yeah.
yes. Yeah,
that's the overall question.
That is the overall question, right? Because you could say a lot of things, but
yeah, you said a lot of good words. But I want to know, how do you ensure that that's carried out? And one example is if someone who has SMI or SFI and is in segregation, how do you ensure that one of your employees is checking in and working with that person on a daily level? Because it says that right in your contract. And that if there is any change, that the person who is in segregation needs a different placement. How do you ensure that those daily visits are happening? It's right there in your contract you referred to a little earlier.
Absolutely. Yeah. No, and I definitely appreciate actions speak louder than words, right? I mean, that's really what this is about, is that we're going to demonstrate through our actions that we're capable of caring for our patients in Vermont. And so how we have sort of tasked our team to ensure that everything in that contract is being done, and I'm going to speak specifically to mental health, is that for each facility, we've added a behavioral health director, a mental health director. This will ensure that we have someone who's at every facility really sort of as the leadership for the team, as well as really sort of following up to ensure that the patients who need these daily follow-ups, who are scheduled to see psychiatry, who are just generally sort of part of our mental health caseload, are getting the services that are required. And how we're doing that is through clinical supervision, regular daily meetings to ensure that we're keeping track of every patient in our system. That means we're talking about individuals who are on suicide watches, those who are in restrictive housing, and ensuring that we are seeing them on a regular basis. And so through our levels of management, we have our local on-site behavioral health directors, and then we have a regional mental health director who's providing oversight to those mental health directors. And then we ensure that these things are happening through audits. We send out a daily report of individuals who are high mental health acuity, SFIs, who's being seen. And so we have a process of accountability to ensure that we're seeing all the patients that need to be seen throughout the day and the week.
What happens if something pops up that is not occurring? That some of your staff is not complying with the contract?
Absolutely. So obviously there's probably human error, which is involved in everything. And so if we have a human error where someone intended to see someone and they missed it, we'll send someone in to see them, or we may have one of our nurses check in on them that evening. If we find that there is a individual who's just one of our employees who's purposely not managing, seeing folks as indicated by the mental health director, then we would obviously meet and work with that individual around those things. And in some cases, put them on performance plans. And if they are not the right fit for our patients in Vermont, then we would move on. But we definitely sort of, manage through CQI monitoring and trying to ensure that we're providing services appropriately to all of our incarcerated individuals.
Representative McMahon, excuse me.
Sorry. Again, all nice words. Have any of these incidents happened recently? Are they happening now? Where people aren't getting medications that they're supposed to, or getting treatment that they're supposed to, or being referred to places and they're not being referred? Is that happening now?
Not that I'm aware of, no. Since we've assumed the contract on July 1, I'm not aware of individuals who have not gotten the follow-up that they wanted or that they were needing, right? So there's a desire for, what a person wants versus what's clinically indicated sometimes, and those two things don't always match. But I'm not aware since July 1 of instances where individuals have maybe quote unquote fell through the cracks, or that we've missed following up with someone that we had indicated that we would.
Other questions? I have one, actually. For whatever reason, right now, I'm kind of stuck in this understanding what happens when somebody is released from custody, and what kind of ongoing support there is between the community mental health provider, if there is one, and the WellPath provider within the facility. Is there communication? Is there, what is in the contract that would provide that continuity of care, and also particularly with substance as well?
Absolutely. Yes, Annie mentioned we added discharge planners to the contract. So essentially we have, we were aware that this was a previous issue and that we wanted to tackle this as one of our things moving into the contract, that we wanted to ensure a smooth, kind of what we call warm handoff to the community. And so we, as Annie had referenced, we have individuals who are in the facility who are kind of managing your day-to-day I'll say normal, I don't know if that's really the right word, releases, or maybe more straightforward releases. The discharge planners that we've added to the contract, which we're in the process, we've just hired and are training and really sort of bolstering out this program. We've had some success developing a similar program in another state. And those discharge planners, along with the director of reentry and recovery and reentry, are going to begin developing more clear partnerships with our community partners. And so the thought is that those discharge planners and the director of recovery and reentry will develop relationships with the community in order to get our patients in a little bit quicker, to have smoother processes of individuals who are coming out of incarceration into the community, and really sort of ensuring that medications are available, working with partners. Obviously, I think housing is a big issue in Vermont. And so working with community agencies to really sort of come up under these folks and ensure that they have as smooth as possible in some situations, transition into the community. And that's both for our detained and sentenced individuals. You know, there are also those discharge planners. We have a lot of individuals when you're detained and you go to court, you're not expecting you to be released and you release pretty quickly. Those discharge planners are able to step in and kind of do that immediate discharge planning to ensure that medications are available for the individual and try to get them, help them get their needs met. And those discharge planners will follow the individual into the community for a period of time, working to sort of ensure that that transition has been smooth. Because a lot of times you'll experience like even the best laid plans don't go as planned. And so the discharge planner follows for a little period of time to ensure that those plans kind of stay intact or are available to kind of reconfigure the plan and find another place for the individual to go.
Representative.
Rebecca.
Yeah, I'm sorry. Thank you.
I wonder if you can talk a little bit about where peers come into play, particularly if they do around your CQI process. That is one place I think we all know that Vermont is not 10 years ahead of everybody. We're about 20 years behind the rest of the nation. So I hope that as you're thinking out, you're building in a space for peers to really have an influence on good outcomes here. And hopefully it's around informing positive change in the CQI process.
Absolutely. So WellPath brings a pretty robust CQI process. So prior to us taking the contract, we did a full review of our CQI studies. So we have studies that cover, I don't know, a bunch of different spaces from mental health to nursing to medical, psychiatry, documentation, et cetera. And so that allows us to gather a baseline of what we're sort of coming into at that point. And then from there, we will build out plans to address things that maybe were not so favorable in the CQI studies. And then also those areas that were, great, we look to and strive to continue for those areas to remain above average in those cases. But as we develop new services, we also develop new CQI screening tools, right? So like discharge planning, WellPath has a discharge planner CQI process, but because Vermont will kind of have its own setup, we'll build our own CQI plan to ensure that we're capturing the right information about whether that program is being successful or not.
Thank you. Representative Golden.
Thank you. Thank you for your testimony. You mentioned earlier that suicide is the highest cause of death in correctional facilities. And I'm wondering what processes WellPath has when there is a suicide in one of your facilities.
Absolutely. No, I appreciate the question because I definitely feel like suicide is a very important topic to be talking about in corrections in general. And so for WellPath in general, we follow the zero suicide model, which is just a national model. And so our goal is to not have suicides. Unfortunately, we do experience suicides. And so when that occurs, our staff in particular, another reason we added the behavioral health directors to each site is that the on-call clinician would then, let's say this happens after hours, the on-call clinician would be going to the facility along with the mental health director and potentially the regional to provide on-site support. I know that DOC has a very robust peer support system, which is great, but they're also there to kind of check in with staff, both WellPath security and residents, just to sort of check in on them. And then we have a continued kind of process of following up the next day to ensure that people are doing well with sort of things that happen. Generally, the suicides happen in a cell house area, which also impacts our incarcerated individuals. And so ensuring that we're doing rounds and following up in that area is also important.
if I could follow up. Do you look at your processes, your flows, or how your clinicians interact over time if maybe something wasn't picked up? I mean, how do you learn from it? I guess is my question.
Learn from if we have a bad outcome or just in general?
I'll learn from a bad outcome, yeah.
Oh, yeah, absolutely. So every suicide attempt, every serious clinical event is reviewed. And so part of that review is that individuals outside of the facility in management within WellPath look at those files to find out what's gone on. In some cases, we're definitely partnering with our DOC partners to find out kind of what they've seen from their end, were checks being done on time, how did the response look? And so we're doing a full review after those events to determine if there is something that we potentially missed, or was everything going according to plan and we just had an unfortunate outcome with an individual who may have been really unwell coming in to the facility. So we do evaluate what we call critical clinical events.
Thank you.
Can I also chime in here?
Please.
I also wanted to add that embedded in the contract, we're very excited about this. We are going to have a partnership with the University of Vermont. There is a group who has been addressing suicide for a number of years. The company's called VOI, VOI, and they have developed an artificial intelligence machine learning algorithm for detecting suicide. And our expectation in the contract is that we will be implementing, the algorithm is called SERAS, SERAS, and we will be weaving this into our electronic health record and into our clinical workflows. This has become a national issue, not suicide, but SERAS. SERAS and VOI have become partners with many, many giant hospital systems across the United States. And the machine learning aspect helps it norm to the population that it's being administered to. So we're extremely excited about this. It's very predictive of people who are going to commit suicide, who are going to potentiate to action within 24 hours of the act. So we'll be working with our partners at VOI to determine how frequently, where and when in our workflow we'll be adding this into our standard screening tools and approach with all of our patients.
You. Representative Wood has a question.
Thank you. Dr. Hodges, I am curious to know about the work that's being done around MAT and the transition process that I know is just, new and getting started in terms of transition planning. Just kind of boggles my mind a little bit, but so it's been my understanding that the allowed medication under Vermont's Medicaid program is different from what has been being used in the correctional facilities. And is there any work to try to bring those two into alignment? So I guess I would say, despite what maybe has been researched, we do know that people have overdosed and died, almost immediately upon leaving correctional services. And part of that, at least, was due to not having consistent medication available to them that was consistent with what's provided, in the community via Medicaid. So I'm just curious about, are there still differences between what's provided within the facilities and what is provided by Vermont Medicaid? And if there are, what are the efforts to try to reduce those differences and or assure that people have access to medication on day one from their release?
Absolutely. I'm going to have Annie help me out here a little bit on the Vermont Medicaid piece, but I will say that essentially, we're 2 months into our contract. And so our thought process coming in is that Vermont offers a wonderful MAT program to begin with. And so our intent was to come in, ensure that patients were getting the medications that were already being prescribed within the facilities, and continuing to move that program forward was our intent around the medication assisted treatment, and ensuring that patients who have an accurate diagnosis and a medical need are being placed on those medications. As far as speaking towards the medication and the Vermont Medicaid, I'm going to hand it over to Annie to answer that piece.
Hi, so yes, you are correct. We provide Subutex, the mono product, versus the Medicaid formulary, which is the dual product, Suboxone. There are many factors that inform this decision, and the department is always open to re-looking at this, re-examining it, and making other decisions as needed. Part of the situation here is a cost situation. Subutex is less expensive than Suboxone. There is also thin research on the presence of naloxone with the Subutex, which is what makes it Suboxone, in reducing overdose in the community. That research found that the presence of naloxone with Subutex reduced overdose if somebody ground up the Suboxone and injected it. So the risk of this actually occurring in a correctional facility is extremely low. And so that was another reason why the department has continued to use Subutex. The third reason, primary reason for using a different medication, is that it also assists us in understanding what is being prescribed and what is contraband. Because there are different colors and formulations of the pills, when we find Suboxone, we know that it's being introduced and that we have a security issue. If we find Subutex, it's more of a medical issue, more of a treatment issue, to reassess that individual, to understand whether or not they're actually receiving the correct dose. Sometimes people divert their own medications, saving small amounts so that they prevent symptoms of withdrawal later in the day if they are a rapid metabolizer, etc. Sometimes it's just a habit of that's the way they've always taken the medication. But that really helps us determine ultimately whether or not it's an introduced medication or a medication that is coming from within the walls. The cost is not the only driver, as I've just said, but what also needs to be discussed and understood is the format. The pill is easy to crush. Medications are typically crushed in the community as well as inside of corrections to help prevent diversion. Suboxone also comes in a film. That's even more expensive than the dual product in pill form. These changes would have a significant impact on our pharmacy costs, and again, would have to be really examined and absorbed in the context of the entire picture of the contract and the annual expenditures.
Thank you for that response and for, the details with all of the things that need to be considered. And I guess I would just ask that, as part of this relatively new transition planning process, that there might be some consideration for people who we know are going to be exiting, who are on MAT in the correctional facility, and we know will be exiting and needing MAT in the community, that, there's some way to effectuate a better transition, particularly around those medications and access to what they're going to need in the community. I've taken just a quick look at your study, Annie. I haven't had a chance to really read through it, but I mean, we do know, and I know that COVID was kind of an overlay of everything, but we do know that there were a number of deaths from overdoses, after being discharged during COVID. And and a lot of that had to do with access at that time. So I appreciate your attention to thinking about this issue during that transition process.
I will add a change in this contract, which we actually have a meeting later this week about, is that the WellPath is required to provide 30 days worth of medication. Whatever active prescriptions an individual is on inside of the facility, they're required to provide 30 days supply upon release. So this is a significant change from the previous contract environment, and one that we hope really supports continuity of care. And it's all medications, including buprenorphine.
We have a final question. I'm sorry.
No.
I just want to move along. Representative Goldman, do you have?
Well,
to that?
if I may, 30 days is a short time, and that worries me because many people can't get in to be seen within 30 days. So I worry, will there be an appointment schedule to guarantee that there's, sorry.
Yeah, I'm so sorry. I just was speaking to the medication, but yes, appointments for every active diagnosis on their problem list are also part of the contract expectation. So it's not just, here's a bag of pills, here you go, find an appointment. It is about connecting to a community provider as well. That's part of the expectation.
Within 30 days.
Oh, yes, yes, yes.
Thank you.
Representative Edmonds, final question.
So I have a question of follow-up of a previous question that was asked about how do you ensure that the staff, WellPath, is carrying out the contract? And one thing that was mentioned is sometimes if a person, one of the employees isn't doing like a daily check or something is occurring, it could be because of human error, or it might be behavior over time that a staff is not carrying through as they should. Is there a process to report that employee to WellPath, the higher ups in WellPath? Or is there also a process to report that behavior to our Office of Professional Regulation?
Yes, to all of the above. So there is a process for individuals who are outside of the DOC to express concerns about WellPath staff. I'd be remiss if I didn't include Annie in this response, but I think perhaps the best option may be to go through our either DOC partners or through our regional office that is in Vermont, the WellPath regional office. Obviously, filing a board complaint with the Office of Professional Licensure is also an option for both individuals who are incarcerated as well as individuals who are in the community. And so we welcome any sort of feedback that we're getting around our employees. We do our due diligence to investigate and ensure that the individuals we have employed in the state of Vermont are providing the best services within the correctional environment.
So you do have a process to report that to our Office of Professional Regulation?
Absolutely, yes. If there is a concern, I will tell you, I've personally filed board complaints in other states as that's my responsibility as a professional, that if I have concerns about an individual who is performing not to the standards within sort of the ethical guidelines or practices, that we are required to file a board complaint. And so that is part of something we would do if it rose to that level, for sure.
Thank you all very much. Very helpful and a good discussion. I would like to ask the committee to think about what the next step might be, and we can talk about it after lunch. We have a committee discussion on the competency evaluations. I don't know what the next steps are, but maybe it's time for a little oversight from the standing committees, Senate, House, to look at prison health care and what we're doing and what we're not doing and what we should be doing. But it could be a recommendation from this committee. I'm very helpful to have this discussion today and understand better. But I still think many of the advocate points that were made at the last meeting deserve a response to some of those concerns. With that, I'm going to switch to community violence. And we have with us Commissioner Morrison, Deputy Commissioner Doherty, and I'm never sure if you're the Dee Marvick, who is the head of the Governor's Violence Prevention, is it task force or?
Yes, sir.
Thank you, task force. I got an interesting email from Matt Valerio recently. And there's a survey out that lists Vermont as the safest state in the nation to live in, the lowest violent crime rate in America among a population of 647,064 people. There were only 1.46 violent crimes per 1,000 people in 2022, including 15 murders, 64 robberies, and 790 assaults. Residents in Vermont have a 1 in 595 chance of becoming a victim of violence. But you'd never know that. President Lawrence of the Daily News, and you didn't have to leave Calvin. But and particularly some letters that I've been receiving, many of you have been receiving about our crime and how we're all responsible for that. I don't, maybe some of you aren't. I certainly am, according to these people. So many of them are anonymous, so I don't know if they are. But I thought it was important to have a discussion of where the community violence program is at and what we're doing in Vermont. And appreciate the three of you joining us today. And maybe whoever wants to start off, Chief, I'm sorry, Commissioner Morris.
Good morning, sir. I think I will defer to Kelly Doherty from the Department of Health. She has some concrete information on the community violence prevention grants.
Yep.
Thank you, Commissioner. Yes, so the Department of Health was tasked with, in collaboration with the Governor's office and with Commissioner Morrison's office and the Office of Racial Equity. We are leading the community violence prevention program as outlined in the legislation from last session. So I can give you an update on
That
where.
was S4, by the way.
Excuse me?
S4. I don't know the act number.
I just know that it's, yeah, I don't remember what the act
Yes.
number was
Yes,
either.
it is.
Before. Okay. Where we are is that we've designed a program such that municipalities and community-based organizations will be eligible to apply for grant funding. And they can use this to expand any existing programs that are addressing causes of community violence or creation of new violence prevention programs. And we're also prioritizing increased access to new or existing program for traditionally marginalized populations that could include LGBTQ+, communities of color, individuals living in poverty, youth, and people with disabilities. So, and the programs will be designed to address the causes of violence that could include addressing gang activity, human trafficking, youth violence, domestic and sexual violence, gun violence, and hate crimes. And priority will be given to communities where programs are designed for traditionally marginalized populations and that there has been an increase in violence associated with illegal drug sales and or drug trafficking, as well as gang activity and human trafficking. So where we are now is this is sitting in our Division of Family and Child Health, where we have some other violence, mostly domestic and sexual violence work that happens. So that was the
we felt like the best place to put it in the department. So that division, along with the governor's office and public safety and racial equity, we're currently reviewing a second draft of an RFP, and we will have a third draft ready to go to our policy team to make sure it's in compliance with the legislation by tomorrow. The RFP will be posted on the BGS site for municipalities and community organizations to apply to. We'll also distribute it widely among our various networks. And we will be holding a bidders conference for any potential applicants to ask questions about the program. And we will be assembling a grant review team that will include state staff as well as community stakeholders to score and select applicants for funding. So the timeline is that we anticipate that the RFP will be posted by October 1st, and applications will be due October 31st. And the award period would begin, would be from January 1st, 2024 to December 31st, 2024. With the extension, with the option to extend for an additional 24 months. So we have 4.75 million in available funds to be spread out over 3 years. The remaining funds will be used for administration and evaluation. And so we don't really know what the grant award ranges will be. It's kind of dependent on what we see when the applications come in.
Can I ask you, what was the intent when we were, at least on the Senate side, and I suspect on the House as well, that this could be, this program, the it was 5 million and got some administrative costs. The program would also might be eligible for federal funds that they could be combined with that are coming. I think I can't remember the name of the Federal Violence Prevention Act, but that there would be money coming to different states to help deal with community violence, and particularly in the substance abuse area that's related to this. So there was the intent that could all be combined in one, and I don't know if the language left as it got finalized, but I think at least in the Senate, the language did allow for the combination of federal funds, other grants that might come.
Right. I'm not aware of those grants. I don't know if Commissioner Morrison or
I thought there was a federal,
the Safer Communities Act or something.
Yeah, Safer Communities Act.
Okay. I will look into that.
Anyway, it was the intent that funds from that could be added to the 5 million.
Okay, great. That would be nice. And we can extend this further. We're currently recruiting for a public health specialist to support the community violence prevention program. And that person will be responsible for administering the subrecipient awards, and that posting for that position closes tomorrow. So hopefully we'll have someone hired by the beginning of November. Any other questions?
Are there other questions for Kelly? Mr. Morrison, do you have any comments on the community violence work? And are we seeing I know in Bennington, they're seeing a reduction, at least in the shootings.
We have seen a reduction in the shootings. I don't have that detail right in front of me right now, but yes, there has been a reduction in the number of shootings in the same time period of quarter 2 of 2023 as compared to quarter 2 of 2022. We continue to work the public safety enhancement team, which is an offshoot of the governor's 10-point plan, continues to work and engage with communities that are seeking to reduce violence in their community. As you know, we've done extensive work with Bennington and with Springfield. Springfield has been a real success story. I don't have the particulars on it, but I can tell you that there's been a combination of events. No one thing has turned the ship around there, but they have seen a real change in their violent crime and overdose and other related type of crime data in the last 6 months. So that's very encouraging. We are in the early phases of beginning an engagement with Brattleboro. Each community is very, very different one to the each. There's no prescriptive way to approach a community and say, we're going to come and the state's coming here to engage with you and do a summit. We're not trying to create a cookie cutter approach. We're trying to very thoughtfully and individually approach each community and get to know what the existing systems are, the existing collaborations, shall we say, the efforts for either community revitalization or community safety are, and so that we can go in and add value and add information, not go in and try to trample or confuse something that is already well underway. So each of these engagements takes months to plan, and then we convene what we call a summit with interested stakeholders. In the run-up to that summit, we hold listening sessions and focus groups, anywhere from 6 to 8 different types of focus groups. Youth might be a focus group, people with lived experience, housing and homelessness might be a focus group, violent crime, criminal justice might be a focus group. So we go in and hold focus groups in advance of the summit so that we can hear from the people experiencing these situations. Those groups, we then facilitate them drawing up problem statements. And during the summit, which is a full day engagement with state actors and local actors, we design action items to address the problem statements that have been identified at the local level. And then we continue to circle back to those groups to see how they're doing. The idea is not for the state to swoop in and solve problems. It's to come in and help them organize and provide more resources, more relationships, more connections, and to sort of keep a cadence up so that outcomes are delivered. And we've seen some really good progress in Bennington, and as I said, some extremely good progress in Springfield. And we're looking forward to our next engagement in Brattleboro.
I know Dee and you also received an email from people in Brattleboro that I received, and I think most of the Brattleboro delegation, or that at least the Windham County delegation, received about the problems at a particular location on Elliott Street in Brattleboro. Is that something that a focus group looks at? How do you deal with that? Quite frankly, I mean, she really covered an awful lot of territory there.
Yep, she did. And, I think that when you think about over the overlapping issues of the crime and disorder, the substance use disorder, the drug dealing, there's no one solution for a situation that she described there. And that's why when we go into these communities, we start by looking at focus group areas, but then the summit is where everyone has visibility into what the other focus groups have determined are the main priorities and the problem statement. And then when we break out into the groups to develop action items, we shuffle the deck. So it's not all the cops and prosecutors in one focus group. They all get dispersed into all the different focus groups to really cross-pollinate problem solving, but also to raise visibility about how problems in one area, solutions or problems can blend over into multiple groups. The short answer is that is a sticky situation that's going to require significant engagement by local and state actors, but also from other partners outside of criminal justice services. And Brattleboro is a unique community. I'm sure you know, anyone who has lived or worked there, they already have a lot of what they believe to be coalitions that are working on this issue. And again, it's never the intent of the state to disrupt any work at the local level, but to add value and maybe resources and connections. So we're treading a little carefully because of some ongoing work that's already happening there. And we're taking extra time to attend community meetings, select boards.
I was using that particular example
Say it again, sir?
what we're hearing, not necessarily it's an example of what we're hearing out in the communities.
Yeah, yes, it's happening all over. That's a very real example of significant problems that need to be approached from a multidisciplinary angle. It's not an enforcement solution will not clean that up. It's going to take multiple partners coming together to address all the underlying root causes that led to that situation. And they're sticky problems. There's no easy solution. So I'm not sure what other information you would like me to provide, but that is the ongoing work of the public safety enhancement team related to sort of deep level engagement with communities. The other piece that we've recently brought online is that the Department of Public Safety has entered a contract with the Crime Research Group, which is well known as the SAC for the state. I'm sure your group is aware of CRG. We have hired them to do 5 deep dives annually into communities beyond just basic crime analysis, but to try to I'll take Springfield as an example. If you trend out Springfield's crime and disorder data, and then you see this big drop off, that's great, but why did it happen? So we need people to go multi-layer and figure out, okay, when was the big federal drug interaction? When were certain high flyers or frequent flyers locked up and taken off the street? When was the new police chief hired? When were new services brought online? When did they get access to, substance use treatment in the community? There's all sorts of things that need to help us tell the story, not just crime analysis, which is raw data. So we're bringing that as a resource to bear with the communities and for the communities that we're doing these deep engagements with.
It's not easy. One of the complaints I often hear is that there's a lack of, in the courts, that we're not locking people up the way we should be. I kind of disagree with that, but the figures are that I don't know what it is today, but there are about 400 to 500 people on detention on any given day in our prisons, which means that we've got a lot of people who are on conditions of release who are incarcerated. But the next meeting, we're going to take a hard look at the lack of a juvenile facility, secure juvenile facility. And we would appreciate at least your comments on what you're hearing and what you're seeing in the communities, if you could do that in October at our meeting.
I would certainly be happy to do that. If I'm not available, I'll certainly send someone with all the right information.
Are there any other questions, Senator Morris?
Yes, I just have one. Good morning. Many of us have heard, I guess my interest or concern may be the statistics in reference to crime pre-pandemic versus post-pandemic. What I've been hearing from individuals is in the legislature's attempt to address housing and homelessness throughout the state of Vermont, we may or may not have been drawing the wrong individuals into Vermont for these apartments, these houses, or whatever else. I spoke to individuals myself who said, you need to do something with this. These are dangerous places, so on and so forth. So I guess my question is, or my concern is, statistically speaking, do we have those numbers pre-pandemic versus post-pandemic? And has it gone up? Has it gone down? Or where are we? And I don't need that answer today if you don't have it, Commissioner. So.
Yeah, I don't have anything sitting in front of me, but it would be helpful if you wanted to narrow the look that you're looking for, either to a geographic area, a town, a group of towns, or if you're truly looking for statewide data, we can do some measurement based on how we quantify. This gets into a really deep conversation we don't have time for, but we can quantify crime as what people report. So what is the initial call type entered as? That's what the perception is of the thing that is happening in the community. And that is frequently very different, Sheriff, than the NIBRS validated data that's been through a whole bunch of things that have noise, such as decisions whether or not to charge, whether or not that person went to a pre-arraignment alternative, whether or not they were convicted. So the NIBRS validated data is going to tell a different level of story than what it is than the initial call type data can tell. So when we start talking about statistics on crime in Vermont, I always try to throw a big caution flag to say, we got to be really clear what you're trying to measure, the geographic area, and whether you're looking for reported data versus validated data that will have been through multiple things that create noise in the system.
Okay, so let's
I'm
go
happy to
back.
get you whatever you need.
Let's go back to S4 as, for instance, Bennington was a hot button as far as S4. And I guess if we could look at, I mean, that hasn't changed, Commissioner, whether it was the Vibers and how you report your crime and so on and so forth. That hasn't changed prior to pre-pandemic versus post-pandemic. Those all came into play prior to this anyway. So I understand your concerns there, but I guess if from my own personal use, if we could look at, say, Bennington and Springfield, you said it's working in Springfield. Those are geographic areas. I'd just like to know the differences between what's going on pre and post pandemic.
Yes, sir. I will get that for you.
Thank you. We know about Bennington.
We know.
I don't want to take up all the time and not let my dear friend Dee have a word with you. So,
Dee, do you have some comments on where we're at with community violence program, prevention program?
I attended the meeting as Deputy Commissioner Doherty had described what's been developing so far with the program, and I did attend the meeting. There's another one tomorrow where we're going to look over the next iteration of the RFP. But I don't have anything more to add. That everything was covered quite well.
I'm going to ask you. You know that what can prevent crime is clearance rates and the likelihood of getting caught. And that takes police in general to get caught, to solve the crime. How bad is our, at least on a state police level, where are we at in terms of the force?
We have approximately 50 to 55 vacancies out of a sworn workforce of 330.
That's huge.
It's not, it's actually lower than a lot of police agencies across the country are experiencing.
Yeah.
Not that I'm happy about it.
Yeah, but I suspect that contributes to the criminal activity if you're less likely to get caught. Are we making efforts? I know that I don't get, other than Channel 3 during the news hour, we don't get Vermont television in Bennington. But on cable, we do get the ads for the Department of Corrections hiring program. And I'm wondering if you have put out similar ads or if you're doing anything in terms of recruitment.
We actually have had a really,
I wouldn't see them in Bennington if they're on local television.
We have, sir. We have a young civilian recruiter who has put out, in the last year and a half, has put out some very, very compelling recruitment material. And we've entered into a bunch of sort of new and promising areas to do recruitment in. You know, the great news is that we had 19 young candidates start pre-basic in this most recent class. I think they're in week 3 or 4 at this point of the regular academy. So we still have 16 in that class, which is double what we've had in the most recent classes. And we're looking to have another robust group of candidates for the August class. So something has, the tide has changed a little bit. And I'm not celebrating yet, but you know, the days of starting pre-basic with only 6 or 7 troopers appear to be moving towards double that. And we're looking to triple that to make up lost ground.
Senator Norris.
Just a follow-up question. Does DPS keep track of recruitment in local law enforcement offices? Do you have an idea of, okay, thanks.
If I might, Chair Sears, if in fact the commissioner or staff, whatever, when they do find that information, if she could just send that to Peggy so she could disseminate it to everyone.
Peggy Delaney.
Well, I do know Bennington has had, I think, 4 recruits recently. They all make it through the academy. That's it. That's it. You know, we're still not up to their staff.
Well, sir, you know, toward that end, this is going a bit beyond the scope of your question about the fear of the risk of being apprehended being a deterrent to crime. But the Department of Public Safety has been awarded a grant that we applied for through congressionally directed spending that will allow us to design with the council and the police academy an alternate path to law enforcement certification. So it's a $1.5 million earmark from Senator Sanders' office. And we are just at the very earliest stages of organizing ourselves to lay some groundwork to get to the point of being able to launch an RFP to partner with an academic institution to create that which was required by Act 166, I believe it was 3 years ago. It's a huge endeavor to build a completely alternate path to the one residential police academy, but that wheel is in motion, and we are very hopeful that that will help us grow the number of people who find joining the career field approachable and not having to step out of their lives completely for 18 weeks to go to an overnight residential academy.
Are there other questions on anything to do with community violence?
Ben does it.
Essentially, there's not so much a question, but just a point of information based on the question you had asked about the federal funding for the Community Violence Prevention Program. Under Section 11 of Act 23, the department can seek federal grants and can use those either from legal settlements related to that or any grant programs for drug or criminal activity. And that actually is a priority use for any federal funds that are gained. Those are supposed to be used first and then can replace any general fund appropriations so that those are then returned back to the fund itself. Right. And then as far as Senator, your question about information, it may not get to you as soon as you would like, but there is Act 40, which was S14, the report on criminal justice investments. The demographic data that you're seeking, if it's available, is supposed to be included in that report. So it may help kind of give a profile of because it's over the course of 3 years. So that's will be released, I think, in 2025. So it's still a couple of years away, but it may not give you what you need right now, but it will theoretically, if it exists, be included in that report.
What bill was that, or?
That was S14, so it became
S14, yeah. That passed.
Yes.
It was S6 that got beat. I'm trying to figure out the bill. Yeah,
but Act 40 or S14 did.
Okay, good, thank you. All right, are there any other questions for any of the witnesses? Thank you so much for being here with that update. It's very helpful.
Thank you for having us.
Thank you.
Thank you.
Take care.
Have a good. We're going to break for lunch and be back at 1 o'clock and discuss competency evaluations with several